community. And I just realized I was on mute, so I apologize for that. So again, this is our fourth web meeting of the Health Intersections Learning Community, and we're going to walk through our agenda for today, talk about our Health Intersections Learning Community that we started just this past spring. It's one of our shorter open webinar series for the Learning Community Resource Center. We'll also have a few special guests joining us today. Dr. Charlie Homer is joining us from the Harvard School of Public Health, among many other roles that he's held in the past as well. And then we have two pediatricians joining us today to talk about access to healthy food and nutrition. Then we also have a community action program from Utah that is going to be joining us and talking about the central kitchen. And then we'll go through some question and answer. So we'll actually have a brief question and answer session after each presenter. We'll take just a few questions after each one, and then we'll take some questions at the end as time permits. And then, of course, we'll go through our different tools and webinars and resources that are upcoming for the partnership. So a little bit about the learning community. The overall purpose is to analyze community action outcomes and identify effective, promising, and innovative practice models that alleviate the causes and conditions of poverty. So it's really all about building agencies' capacity to fight poverty throughout the whole network across the nation. So the national webinar series that I referred to is this Health Intersections. So we're exploring these connections within the health sphere. And the first one that we focused on in April was the social determinants of health. We also focused on housing and substance abuse. And we've recorded each one of these so they can be viewed by you, even if you weren't able to join the live event. Then as far as the food and nutrition webinar, that is happening today, July 25th. So this is kind of a picture of the overall Health Intersections Learning Community and how it's progressed. We've had subgroup calls for each learning community, so we'll announce that date and time that's going to be corresponding with this national webinar after the webinar. So stay tuned for that. I believe it's August 2nd, and I'll give you the time at the very end. But that's an opportunity for you to engage in further discussion with your peers, as well as Dr. Charlie Homer in this important topic on food access and nutrition. So the LCRC team that's kind of behind the scenes on all of this, we have Dr. Jarl Crocker, our Director of Training and Technical Assistance. Tiffany Marley is our Project Director. We have two Program Associates on the team, Hyacinth McKinley, as well as Liza Porras. And then myself, I am Courtney Kohler, the Senior Associate with the partnership. So we always like to start out our webinars with the promise of community action, just to kind of ground us in the work that we're doing. So you can say this to yourself at your desk along with me. Community action changes people's lives, embodies the spirit of hope, improves communities, and makes America a better place to live. We care about the entire community, and we are dedicated to helping people help themselves and each other. So a couple housekeeping items that we like to bring up. Everyone is muted upon entry, usually on these webinar events, but please make sure you do remain muted throughout the webinar to cut down on any background noise. You can enter any questions that you have in the chat function, as well as if you're having any audio issues. Please use the chat function for that as well. Whenever we do the questions, feel free throughout the presentation to go ahead and enter those in as you think of them, and then we'll backtrack to make sure we hit all questions. There is a chance that if we do have lots of questions, we might not get to all of them, and if that is the case, we will circle back through and make sure they're addressed after the webinar and send out a Q&A. All right, so to introduce our subject matter experts for today, we have Dr. Charlie Homer, Dr. Deborah Frank, as well as Dr. Shikha Anand. And so we'll be hearing from each of them today, and then we will also, after each subject matter expert goes, we're going to hear from our community action agency showcase that we're doing today, which is Utah Community Action out in Salt Lake City, Utah. And we have Joni Clark, the Chief Development Officer, joining us from there. All right, so Charlie, I'm going to go ahead and turn it over to you, and appreciate all your time on this webinar today.
Terrific. Are people able to hear me okay? Courtney?
Yes, I can hear you great.
Great. Well, again, thank you so much, Courtney, and it's really a pleasure to be here with everybody today. Just by way of very brief background on myself, like Drs. Frank and Anand, I am also a pediatrician. I founded and led for nearly 2 decades a national nonprofit called the National Institute for Children's Health Quality, which works to improve the quality of systems that promote well-being for children and families. For the last 2 years, I served as Deputy Assistant Secretary for Human Services Policy at HHS, and I worked closely with your colleague Jeannie Chafin while I was there. My job today is to set the stage for a more detailed exploration of the intersection between poverty, food policy, nutrition, and health. We hope this will help you recognize how important your daily work is for child health and give you some new ideas for how you might focus your efforts going forward. We want to encourage your ongoing activism, not only on the ground in the programs that you operate and run, but also in local, state, and federal policy. If I could have the next slide, Courtney. To provide just a little bit of grounding, allow me to describe 2 composite patients typical of many I saw when I was in clinical practice at an urban primary care setting in inner city Boston. One, whom I'll call Jamal, is a young boy. Due to efforts of groups just like yours, his mother was able to recently start an entry-level job in retail. She was able to do so in part because her child received a child care subsidy and was placed in a small child care center. But after the mother was in her job only for a month, her child was expelled because he hit another child and was difficult to control. Later that same day, I might have seen a young Latina girl named Roberta who had a body mass index that placed her at the high end of the range that we call overweight, greater than the 93rd percentile for girls her age. She had other indications, high blood pressure and changes in her skin, that indicated diabetes might not be far behind. If I could have the next slide. As a doctor, my first inclination would be to treat the symptoms that were before me. I might send Jamal to a specialist for a more detailed behavioral assessment. I might suggest that the mother and the child together might enter in some type of program for parent education and behavioral management. And if the child met certain behavioral criteria, I might even prescribe medication. Similarly, for Roberta, I might take a more detailed dietary history. I might refer her to a weight clinic and conceivably start her on medication for her high blood pressure. Next slide. But if this were all that I did, I would have missed the primary underlying diagnosis, the cause for the behavioral issues in Jamal and the major contributors to obesity and the metabolic changes in Roberta, because it is likely that the social conditions in which these 2 children lived, and particularly their lack of access to sufficient and healthy foods, contributed substantially to both of their health conditions. Next slide. We've already had a webinar on the relationship between social determinants and health. So you know overall that the poorer you are and the poorer the child is, the more likely they are to be in poor health. This slide indicates that poor children are more than 4 times as likely to be reported by their parents to be in poor health than the most affluent children. The next slide is for adults, but comparable data exists for children, which indicates that a variety of indicators of depression, in this case sadness, hopelessness, and worthlessness, are also associated with income. The poorer you are, the more likely you are to have these markers. Next slide. Many of you, I suspect, have seen maps that indicate the association between zip code or stops on a subway map with lifespan. You've probably heard the saying that says your zip code has a greater influence on your longevity than your genetic code. This is a subway map of my city of Boston, and it shows that diseases related to nutrition, in this case diabetes, also show that same association. Rates of diabetes in poor communities, Maverick in the upper right-hand corner, which is in East Boston, Dudley Square, which is in Roxbury, Mattapan, and Dorchester, all of which are poor communities, have much higher rates of diabetes than people who live near the Arlington Street Station in the Back Bay or the rapidly gentrifying Fenway. Next slide. We've known of these associations between poverty and poor health for a very long time. What's relatively new is that we now have a much better understanding of how disadvantage, the stress of not knowing whether you'll have enough food to eat, for example, translates into these medical and behavioral problems. We know, for example, that excessive stress at critical points in a child's life leads to the underdevelopment of certain parts of the brain that control our ability to pause and consider the implications of our actions. This is called the prefrontal cortex. We also know that other areas of the brain that trigger the flight or fight response are hypersensitive when exposed to excessive stress. And this causes prolonged release of hormones that trigger chronic inflammation that can contribute to these conditions. Next slide. These exposures are not destiny. They can be buffered by strong relationships, and there are ample opportunities for recovery. Nonetheless, the pathway is clear that early exposures to poor nutrition and other stressors can lead to changes in our bodies that in turn lead to both susceptibility to diseases, our impaired ability to do well in school and get a job, and even poor decision-making about health behaviors. Next slide. You know from your daily work how widespread economic disadvantage is. Roughly 1 in 5 or 1 in 6 children in the U.S. are poor, depending on how you measure it. Similarly, 1 in 6 children in the U.S. live in households that are food insecure. And roughly 1 in 6 children are obese, that is, above the 95th percentile of historic norms. You'll see from the later presentations that not each of these is perfectly correlated with poverty, but they are all closely related. Next slide. The next presentations will go into these issues in much more detail. They should help you better understand the importance of food insecurity and child obesity among those whom you serve. They'll help you understand which policies and programs are most likely to have the greatest impact on these outcomes. And you'll hear as well some models of what you can do to best address these concerns and promote the health and well-being of your communities and their residents. Next slide. Allow me to briefly introduce the next 2 speakers. I'll mention both of them now so we can be a little quicker as we go along. Back to the next previous slide. Dr. Deborah Frank is a professor of child health and well-being at Boston University School of Medicine. She is the founder and principal investigator of really the premier organization in the U.S. focused on the relationship between poverty and child health called the Children's Health Watch. And she's the founder and director of the Grow Clinic for Children at Boston Medical Center, which serves children with substantial undernutrition. Dr. Shikha Anand most recently served as the National Medical Director for Walmart's Care Clinics. Prior to that, she was the Chief Health Officer working with me at the National Institute for Children's Health Quality. Prior to that, she was Director of Pediatrics at a federally qualified health center and was also Medical Director of the Fruit and Vegetable Prescription Program offered by Wholesome Wave. She has both have an obvious deep commitment to community health and to caring for underserved children. Deb, you're next. Thank you very much.
Very kind introduction and for the opportunity to speak to so many people that work in agencies that I have deep respect for and work with every day. Next slide, please. As Charlie was telling you, I am presenting work from Children's Health Watch, which involves 5 hospitals across the country, all of which treat low-income children. Our goal is to both produce scientific research that is timely, and try to use what we've learned to give evidence to state and national partners to inform policymaking. Next slide, please. As you know, food insecurity is a widely prevalent social determinant of health, but we all know that it is not the sole social determinant, and in fact, these needs are often in a vicious cycle where families cut back on one survival need in order to meet another, depending on the month or the time of the month. But they all independently contribute to ill health, and each one worsens the other, and together they are even worse for health. Next slide. Food insecurity is a pediatric disease. If you have children in your household, you're twice as likely to experience food insecurity as if you're an adult-only adult-only household. As you heard, about 16 million children are in households where the parents tell us they don't always have enough to eat. And the younger the child, the higher the risk of food insecurity in the family, although families work very hard to protect their youngest children, largely because lack of sufficient child care prevents many caregivers from participating in the workforce. Next slide, please. We have tested and validated, and now it is also, other researchers have in families with young children, and now other researchers have done the same in adults, a very brief screen that community providers can use to identify food insecurity in their clients, and also, if you keep a tally, to identify the prevalence in your neighborhood or organization. You have to be very tactful with this, of course, and I often say lots of families tell me that things have been kind of tough recently. Can I ask you a couple of questions about your family? Would you say that it was never true, sometimes true, or always true, often true, that within the past 12 months we worried about whether our food would run out before we got money to buy more, and within the past 12 months the food we bought just didn't last and we didn't have money to get more? Either one of these questions, if answered yes, whether somewhat true or very true, often true, identifies families who are food insecure. It's very important not to just ask it as a yes-no question, because most parents will just answer somewhat true because it's too embarrassing to say often true, and also they're afraid of child protection intervention. But either somewhat or often true is a red flag. Next slide, please. I'm particularly worried about families with the youngest children. As you know, the first 1,000 days of life, which include both the prenatal period and the first several years after birth, are critical for brain growth and human health. I often explain to people that it's like a unionized construction site. The crew is only going to work for certain days and certain hours, and if the bricks are not delivered when the crew is on site, the building doesn't get built as well. Nutrition are the building blocks of brain. Next slide. And of course, these most vulnerable children are also the most invisible children. Many of them are only visible to their families and their health providers. Those of you who run early Head Starts and Head Starts have access other ways, but it's very important that these children be engaged in health care, because neither food insecurity nor malnutrition are eyeball diagnoses. Next slide, please. There are a wide range of facts in the medical literature of which you should be aware about the associations of food insecurity, even considering other background issues, and health outcomes, which suggests that if you could decrease food insecurity, you might improve some outcomes. Next slide. The impact of food insecurity on children begins here in the womb and even before conception if the mother is malnourished or folate deficient. Next slide, please. Women who are food insecure in pregnancy are more likely to have children with birth defects, neural tube defects, like this poor dead infant. Next slide. And much more prevalent outcome is the fact that they're liable to have low birth weight babies. And as all of you probably know, babies who are born under 5 pounds, 12 ounces at birth have a much tougher time in growing, learning, and staying healthy. And so increasing the number of babies who are born low birth weight can disrupt the child's health for a lifetime. Next slide. Even if babies are born at a good birth weight and the mother is adequately nourished in pregnancy, there are a huge number of impacts of food insecurity on child health after birth. Even compared to other low-income children, children whose families tell us they are food insecure are more likely to have asthma, are more likely to have to be hospitalized, to have iron deficiency anemia, decreased bone mineral density, meaning they're more susceptible to fracture, more susceptible to lead poisoning, and to have very poor oral health. So that hunger vital sign identifies children who you really need to look at carefully from a health perspective. And conversely, if you have a child with adverse health outcomes, as Charlie told you, you need to look into food insecurity. Next slide, please. It is an extremely expensive problem for our country. If you're interested in saving healthcare costs, one of the cheapest and quickest things you can do is decrease food insecurity at the national level. About $500 million a year is required for the excess hospitalization costs, that is, the costs that wouldn't have occurred had children not been in food insecure families, for food insecurity in children under the age of 4. So when you're advocating with people, even if they don't care about families being in distress, they may care about health care costs. And obviously the effects on continue on adults throughout the lifespan. Next slide, please. Remember that the most vulnerable organ in the body to food insecurity is the brain, whereas the growth can get better if children are refed, and the susceptibility to many illnesses also. The brain effects may be much more long-lasting. Remember that although the size of your brain, the structure, is the most vulnerable in early life, how your brain works is sensitive to the quality and quantity of what you're eating throughout your life. And the brain can't store food, unlike the rest of our bodies. So if you know yourself that if you've missed a couple of meals or fasted for your religion or whatever, that you can sort of drag yourself around, but it's hard for you to focus, think clearly, show a lot of initiative, and children are the same way. Next slide. Young children in food insecure households are 40% more likely to be at developmental behavioral risk than other low-income children. If you have a droopy, ill-behaved, slow child in your Head Start, you really might want to think about this. Next slide. Long-term, the effects are still continue. Kids who have had early food insecurity and kids who themselves are currently food insecure have more trouble with everything that allows them to succeed in a knowledge economy, language, memory, matching what you see to what you hear, attention, modulating activity and affect. They can either be, angry and bouncing off the walls, or kind of apathetic and sitting in the back of the class and nobody cares because they're not causing trouble. And also they're klutzy. Next slide. In food insecurity in school-age kids is tied up not only with kids being depressed and having internalizing problems, but kids like Jamal being aggressive and fighting and disrupting their classes. So again, even if people don't care about someone else's child, they should care about their own, sitting next to a disruptive child who might not be so disruptive if their family's food insecure. Next slide. Child and adolescent food insecurity, either having been food insecure as a child or being concurrently food insecure as an adolescent, is linked to mental health, including suicidal ideation, which you know is one of the leading causes of death in adolescents. Next slide. Well, can we fix it? We can if we wish to. Next slide. There are emergency fixes, which I think we all engage in. One is emergent medical care. Next slide. And another is providing emergency food through our various, next slide please, various philanthropic efforts, whether it's food in pantries in hospitals, which was pioneered at Boston Medical Center where I work, or fruit and vegetable prescriptions, food vans, many ways to do this. But next slide. Just like an emergency room is not a healthcare system, emergency food is not a successful system for preventing and treating food insecurity. Next slide. Only 1 in 20 of the food that is needed in this country and that goes in this country to prevent and treat food insecurity can be provided by the philanthropic network. The rest depends on various forms of public funding. So when you hear people say, well, our philanthropy can do it, our CAP can do it, food pantries can do it, the answer is anybody who's worked in that setting knows they can't do it. But it's a good excuse for withdrawing funding from the public programs. And you need to answer saying, yes, we need donations to our food pantry, thank you, but it's important to realize that this is not something that we can solve without massive input on behalf of all of us. Next slide. At the moment, there is at least a $10 billion cut proposed to SNAP in the Farm Bill. This is a compromise, believe it or not. It could have been worse, but there's all sorts of horrendous stuff in the current budget proposals, not only to cut SNAP by like 20 to 30%, but all other child nutrition programs, school meals, CACFP, even WIC. So this is a real time that people should be yelling and screaming and asking their state representatives and leadership to represent to the federal government that this is devastating for health and for the well-being of the future workforce. Next slide. I want to particularly talk about SNAP and WIC, which are the only 2 federal programs which actually feed people in their families. All the others are done in some sort of congregate setting. And they're kitchen table programs, and that's a value that perhaps you can draw on when you're trying to advocate for these programs. Next slide, please. I know that CAP agencies not only run Head Starts, which access CACFP, but do often heroic jobs in emergency food and other creative interventions that you're going to hear about. But one thing that CAP agencies can do, and is done in Texas, and you may wish to work at your own state level to implement, is they have actually trained staff and set up kiosks to help families apply for federal benefits. As any of you know who've applied yourself or tried to help someone apply, these applications are very bewildering, and even for people with lots of education and English fluency, it's hard to get them right. But this way you can leverage the fact that people are comfortable to come to the CAP. They're often not at all comfortable to go to a welfare office, and walk them through what's needed so that they can apply for programs not only to feed their family at the kitchen table, but also to access other important components of care like health care. Next slide, please. We found that, some of my colleagues do e-referrals now, screening families for food insecurity in the health environment, and then sending, with the family's permission, an e-referral to the local emergency food provider, or to who not only will help them find an emergency food setting, but also help them apply for benefits. As you can see, unless you have a navigator to help walk you through this, just making the referral is not wildly effective. But you can just about triple your impact if there's a live human on the other end who can help people get through the system. Next slide, please. Well, you may say, why bother? I mean, at the national dialogue is very disenfranchising of people in need. And I would suggest that we do need to bother. Next slide. Because we're talking real children. Next slide. And real children can get better. Thank you. That's it. And if you want more information for advocacy in a scientific, we both have scientific papers and we have advocacy briefs aimed at a non-scientist population, please feel free to go to our website. Thank you. And I'd now like to introduce my colleague, Dr. Shikha Anand, who, while I spend most of my time worrying about underweight children, she spends most of hers worrying about overweight ones, which are really both sides of the coin that you see with food insecurity. Thank you.
All right, well, as this is loading up, just wanted to check in and see if there are any questions at this point for Dr. Frank. I haven't had any come in chat just yet, but I'll give just a couple seconds to see if there's any that are coming through now. Okay, we did have one question, not specifically related to the presentation, but related overall about whether there'll be printable slides available for this webinar. And yes, we will have a PDF of the slides available, and we'll post it to our website as well as the lcrcweb.com learning community blog.
Great. Thank you, Courtney. Shall I go ahead and get started? Nothing
sure,
else
yes.
Come in?
Yes,
Wonderful.
Thank you.
Well, good morning, everyone. I'm really excited to be here and talk a little bit about something I'm incredibly passionate about, which is food access and promoting access to healthy foods among the underserved. As we go through, I will talk a little bit about food access and how it relates to obesity, and then go through at a very high level some of the programs that exist mostly in the philanthropic space to combat, the lack of access to healthy foods in the underserved. But there'll be time for questions at the end. I'm going to go through at a high level, so if you want more details about any of the programs, happy to speak about that. So let's talk just a little bit about food access and why it's important. Debbie talked a bit about food insecurity, and we know that central obesity is about 1.5 times more likely in adolescents that come from food insecure households. So there is a direct link between food insecurity and obesity. And there's also, as Charlie had alluded to, a link between food access and vulnerable communities, those that are food insecure. And really, you know, we know that neighborhoods with better access to supermarkets have healthier diets and reduce a risk for obesity. And that's in part because healthy food is typically more expensive and has more potential for waste. So the smaller stores that exist in underserved communities often don't stock those foods. And then they're often less appealing. So even when they're available, studies have shown that often low-income residents who are shopping at bodegas or convenience stores really don't purchase those foods. They don't select them. And this is to some degree led to a public perception that, you know, that underserved families don't prefer healthy foods. But really, I think it's much more about access. And then you have this lack of fresh food access, which is, you know, made even worse by the fact that lower income communities have more fast food restaurants, more outlets for unhealthy foods, and they're typically very densely located around schools. So that kind of creates the challenge we see. There are really two components of healthy food access. The first is financial access, and more than 15 million children live in households that are food insecure, right? They just can't afford to feed their families. And food insecurity exists in every county in the U.S. So, you know, none of us are completely insulated for this, and certainly not in the communities you serve. But you know, even where you may live or places that you think of as wealthier, they also suffer from food insecurity. And then there's the physical access component that I spoke about a little bit, which, you know, the stats are that 6.2 of Americans live in a low-income and low food access tract. And the USDA, I'll go through a few of their maps, but the USDA has really nice definitions and really nice stats on this for any of you who want to explore this a little bit more. And 4.2 of U.S. housing units, and that includes all types of housing, you know, from freestanding homes to housing projects, et cetera. 4.2% are at least a half mile from a store and without a vehicle. And the USDA has declared lack of access to a vehicle as really the biggest contributor to food access in the United States because of this. Move on to the next slide. So looking a little bit more deeply at financial access to healthy foods, and you know, there are some statistics on the right, but more than 15 million children live in households that are food insecure. And federal assistance programs are essential, as Debbie said, but they're inadequate. So I completely agree with Debbie that, you know, SNAP and WIC are pillars of food access in underserved children, but they actually don't have enough total funding to you know, offer healthful foods to all these families, and they don't cover every child or every family. Particularly, you know, some people are not eligible for these programs, and others are afraid to access them for a variety of reasons. You know, they may have issues, legal issues that they are worried will connect. They may be undocumented immigrants for a variety of reasons. So actually, for two reasons, they become inadequate, and they don't actually serve everyone you would hope that they would serve. I'll move into the next slide. So I'm going to quickly show you a couple of graphs. I tend to be a visual learner, and so to really get a sense of the impact. And this is the total population looking at those with low access to a store. The most recent kind of map data is from 2010. And if you look, I mean, these dark red areas, 30 to 100% of the population has low access to a store. And so that's a pretty astounding number, even for someone like me who's been working around food access for a long time. Next slide. And this is a breakdown for children. You know, it's a little bit better, but still, you know, you have 10 to 35% of the population in these of the child population in these dark purple areas that really don't have access to a store. So, you know, they are, again, their families are going to be more reliant on foods that are easily stored. So, you know, if they have a choice between lettuce or, you know, rice, they're going to choose the rice because it's more challenging to access the lettuce, to store the lettuce, et cetera. So that really drives a lot of families' food choices. Next slide, please. And the third is really combining income and access to a store. So when you look, the penetration is deepest of low food access is deepest in those who are low income. you know, and that's what you'd expect, and I think we've all heard this in various ways. But when you look at, you know, a state like New Mexico, where, you know, the majority of the state is really falling in that 10 to 72% that are low income and low access to a store, you start to realize how pervasive this problem is, and really how you need a combination of the blanket kind of federal solutions that really aim to target all Americans, and then, you know, hyper-local solutions that really look at the community, look at the population, and respond to those needs. So in my mind, I don't think that this can work without a combination of both really strong federal programs and then really strong local solutions, if we're truly to get to healthy food access for all Americans. Next slide, please. So I've broken this talk down really into three. There are many, many areas in which we can address food access. I've broken the talk down into three major areas, you know, the supermarket, superstore, bodega, and then the farmers market initiatives, and then the kind of school and child-focused initiatives, most of which center around schools. There are also, as Debbie said, there are, you know, mobile fruit and vegetable vans. There are a lot of, you know, there are green carts in New York. I've done work there. There are a lot of different outlets and a lot of places in the system where you can work, which is the good news. And every community is a little bit differently made up in terms of what's available. But I'll focus on these big three because they tend to be fairly ubiquitous throughout the country. So for supermarkets, superstores, and bodegas, there are a variety of different avenues. The first is thinking about healthy food financing initiatives. That's what they're commonly called, modeled after a program in Pennsylvania led by the Food Trust, to really look at how to bring in retailers into underserved communities. So often, you know, grocery store chains won't want to come into an underserved urban neighborhood, for example, because they're worried about their profit margin, right? Their primary responsibility is to run a business, and they're afraid they can't run that business there. So the principle of the Healthy Food Financing Initiative is really to think about how to change the incentives to allow, you know, those stores that have more offerings of fresh and healthy foods to come into neighborhoods that don't really have them. And there are a variety of different funding options for this and a variety of levers that are used. And they have recently had federal backing in the last 5 years or so, where they are increasing around the country. So, you know, for all of your communities, something to think about whether or not you have access to this, or, you know, whether there's something that you can get involved with around bringing in grocery stores or superstores. You know, obviously that is a slow road, you know, to plan, to find a space, to plan, to create a store. All of that, you know, typically is a 3 to 5 year cycle. So maybe not the most agile way to work, but certainly something that once it comes in lifts the entire population, because it is access for, you know, the entire community, the entire neighborhood. The second piece that there's been a lot of work on is in-store promotion. And so one of the challenges around bodegas and even grocery stores in underserved community is that food placement tends to be different, that you find, you know, typically things at eye level are unhealthy things, that you really often have the healthier foods kind of out of sight and out of mind when you're shopping in the store. So, you know, really looking at food placement within and among aisles, and again, actually the Food Trust has done a lot of work on this. But there have been a lot of initiatives around the country where people have worked with retailers to think about how to place foods better so that populations make healthier choices. Shelf labeling is another piece. So in some way, flagging foods that are healthy. You know, some have kind of a thumbs up. You know, they're very local approaches. Some kind of show nutritional or caloric content. That's a little more challenging to do, but I've seen that done as well. There are a variety of different ways so that someone who's shopping and trying to understand what's healthy doesn't have to pick up every can and look at the back of it one by one, because it's a fairly onerous process. Healthy food samples, so shifting the sampling, so rather than, you know, giving those little tiny cups of Doritos or something like that, giving something that is more healthful, like cantaloupe, in a population that may not have ever eaten a cantaloupe. So really getting people to try things to kind of decrease their bar for purchasing. And then healthy checkout is another big thing, and that's actually occurring both as part of some of these food access initiatives, and it's actually occurring in higher income communities as well. And that's really, when I was a kid, every aisle had candy in it. There was always the thing that you'd ask your mom to buy as you were going through the aisle. And now actually in some stores it's some lanes, and in some stores it's all lanes where there's no unhealthful food kind of right next to the counter. So the idea is that you may impulse buy something different, like a bottle of water or something like that, or that there's nothing available to impulse buy. And then the last piece is product labeling. So this is around large retailers, and I'll get into this a little bit more on the next slide. Oh, and so one of the things I kind of wanted to go through around the USDA stats is I showed you a bit of the problem, but I also want to kind of talk about the problem from the perspective of retailers. So if you look here, this is really, it's a little bit of a complicated map, but it's looking at the change in SNAP authorized stores. So whether there is an increase or decrease of stores that take SNAP benefits, right, what was formerly called food stamps, because obviously there's one piece around bringing a store into the community, and then there's the other that they have to actually accept the type of currency that you have if you're a low-income family, which is typically your SNAP benefit. And so if you look, even in the time between 2008 and 2012, so in an administration that really had healthy food access as something that they heavily promoted, you still have pockets of the country where they are decreasing the number of stores that are authorized to use SNAP. And sometimes this is because they no longer want that benefit. They don't like the population that comes in with SNAP benefits. Sometimes it's because they feel like they're not being appropriately reimbursed. And sometimes it's because they don't do their paperwork appropriately, and they don't, the administrative burden becomes too much of a challenge. So it's not always volitional. But if you look, there are kind of a lot of areas, particularly in the center of the country, where there's a decrease in SNAP authorized stores. And, not that many places in the country where there's a big change in terms of accepting SNAP more. If we go to the next slide, there's a similar map for WIC. So again, right, these are benefits that families come in with, but if stores don't accept them, it's incredibly challenging. And if you look at WIC, the change is even worse. More of the country is really in that negative space in terms of percent change. So, for those of you who are working in Head Starts, who are working with young children, many families around the country really can't use their benefits without traveling quite a distance. And when you look at places like, again, like New Mexico, a lot of the country is on the decline in terms of accepting WIC. And so, people may have to travel very, very far to get to use their benefits for healthy foods. And there isn't great data, mixing healthy food access and kind of WIC use. This is kind of the best data that's out there, but you can imagine that having both of those challenges together may make you drive really significant distances. So you may be driving, 30 or 40 miles to get to a store, and you may not have a car, and you may not have money for gas, and so it becomes incredibly challenging. Next slide, please. So I'll briefly go into the example of Walmart in terms of the large retail space, because they've really taken a big stance on this, in recent years. And as Charlie mentioned, I most recently served as the National Medical Director for Walmart, so was involved with some of this work. And so they made a commitment, in part with the former First Lady's Let's Move initiative, to really revamp what they offered to families. And many of the people who shop at Walmart are underserved, but there's a great population mix at Walmart. So the first thing that they did was reduce sodium and added sugars in their packaged foods. So for any of you who have ever shopped at a Walmart, there is a lot of private label food. Walmart tends to work with big vendors and get their own foods made. So they actually can control their supply chain in a way that most other retailers cannot. And so really made a commitment and really pushed the vendors to reduce sodium and added sugars in their packaged foods. And so trying to kind of preserve the flavor of the things that they were serving, but really get rid of kind of the excess sodium and sugars. They made a commitment to reduce the consumer cost of fresh fruits and vegetables, and this is an interesting initiative in that some of what they did was around the sourcing, where they get their fruits and vegetables from, but a lot of what they did was actually around the transport and trying to decrease the transport cost, because that is one of the big challenges with fresh fruits and vegetables, particularly when you get to rural food deserts in cold areas that don't have a lot of growing capacity. So that was that's another big pillar. They started relabeling kind of better for you and great for you. They're really starting to think about the caloric composition of foods and have nutritionists working with them to think about, kind of nutritionally dense versus nutritionally poor foods and just making it really simple for the consumer. So better for you is kind of that middle tier, neither incredibly healthy nor incredibly unhealthy. And then great for you is really much more healthy, and there are specific criteria around that. And with that, they actually decrease their prices on many items in the better for you category. The great for you is a new label, so we'll see what happens with that over time. They opened 375 new stores in urban and rural USDA designated food deserts. So there's now the concept of the Walmart neighborhood market, which is it is not a big Walmart because there isn't often that much space available, particularly in urban areas. It is a little bit more like a convenience store. Some of them are attached to gas stations, but the idea being that if they open these stores, if a major retailer opens stores like this and has the channels to acquire healthful foods, that they can actually more easily do things like stock fruits and vegetables within a convenience store setting than, maybe a 7-Eleven could, or certainly than an independent grocer could, an independent store could. They did some work which recently got a lot of press around standardizing their expiration date labels. So, this has come up a lot with the former CEO of Trader Joe's, who's running initiatives around that here in Boston, around, whether the expiration date guidelines are too stringent, and whether low-income families are actually throwing out foods that are perfectly edible. So in that line, Walmart has actually standardized their expiration date labels and, said better if used by. The terminology is a little bit different, and really the idea is to tell people when foods are freshest, but not promote them being discarded until they actually need to be discarded. And then, of course, the Walmart Foundation is huge, and there's been 10 million to charitable organizations that support healthy eating. So they've donated a lot. They intend to continue to do that. And for those of you who are working in this space, each Walmart store, this isn't commonly known, but each Walmart store, the management actually has the ability to donate locally to whatever community initiatives resonate most deeply with kind of the Walmart in that community. So it's a great source for if you, are starting a backpack program, which we'll get to in a minute or something like that. It's actually a great resource, and it's worth kind of connecting to store management at your Walmart to determine, because they actually have a fair amount of funding at their discretion. There's a complex algorithm depending on how much revenue the store generates, but it's significant enough funding to help you kind of launch a program. So it's good for everyone to know. Next slide, please. So I'll talk a little bit about farmers markets. And really the goal of farmers markets is to bring produce into underserved communities in a more quick way than bringing in retail. I mean, that's not the only goal, but that's certainly important, right? So, I mean, where it takes 3 to 5 years to get retail in, faster if you've got a big company like Walmart with a lot of resources, but in many areas, 3 to 5 years. A farmer's market, if you start to plan now, you can have one for next summer, and even if you did a little bit later in the season. So that's one important piece is bringing fresh produce and often organic produce in. And the other piece is really helping sustain the markets and farms. So, farmers are challenged, right, in terms of their finances. You know, the USDA has a lot of funding for big farmers. They've done a little bit better by small farmers in recent years, but really the challenge is that for a small farmer, you know, if it's a bad crop year, it's really difficult to stay afloat. So the markets and the traffic through the markets actually helps them substantially in terms of their finances. And so in terms of the farmers market programs, there are really kind of two prongs to it. The first is really the market-focused programs. So bringing in EBT, which is essentially the ability to use a debit card for your SNAP benefits, bringing in those machines, so kind of a credit card swiper, but it has to be set up for EBT. You can't just use any credit card swiper. Bringing those into markets, there's been a huge push around that, and it's actually been picked up by the USDA, and they've actually provided a lot of funding around the country to allow that to occur so that low-income people don't need to use their cash. They can actually use their food benefits to go ahead and purchase at the farmers markets. And then there's been a lot of focus on doing SNAP outreach at the markets. So as I said earlier, there's under-enrollment around SNAP, right? Many families who are eligible don't actually use their SNAP benefits. They don't actually enroll or their food stamps. So there have been a lot of initiatives for families who may, and this is one of the big target populations is really new immigrants who tend to be a little bit afraid to sign up for federal programs, particularly if they're undocumented. And then they may actually shop because they're accustomed to getting fresh produce in their native country. They may actually still shop at the farmers market, so they tend to be one big target population for the SNAP outreach in the market. And then there's the consumer-focused initiative. So SNAP and WIC matching programs are increasingly common. So the way in which it works is if you are going to use your SNAP benefits at a farmer's market, you may receive 2 to 1, you know, in some places, you know, I've seen everything from 1.3 to 2 to 1, where you'll get kind of more produce for your dollar because they'll treat your dollar like $1.30, or they'll put money back on your card when you use it at farmers markets. And often those funds are privately matched, although in some areas of the country they've either gotten a federal grant or used state funding to make that be much more widespread. And then the last piece is something that I've been very involved with over time, which is produce prescriptions. So really the idea here is linking food and health much more clearly, and having clinical teams really help promote access to healthy foods by providing fruit and vegetable prescriptions. We'll talk about that a little bit more on the next slide. So again, an example that I am familiar with, I reside outside of Boston, so I'll give you the example of Massachusetts. So in Massachusetts, 150 out of 245 markets accept SNAP via EBT, so meaning that they have the machines and people can use their benefits there. At many of these markets, there is a SNAP outreach program. There is a statewide healthy incentives program, which is SNAP dollars that are used at the farmers markets and farm stands are matched up to a household cap. So rather than a straight matching of a 2 to 1 or a 1.3 to 1, it's actually based on household size. So for households of 1 to 2, they get an additional $40 a month. For 3 to 5, $60, and for 6 or more, they get $80 a month. And that's a pretty significant bump on the SNAP benefits for a household. They're very helpful to families, certainly in the ones that I've spoken with about this. And then the last piece is the fruit and vegetable prescriptions. This program that I helped start, that's run through Wholesome Wave and actually now has a partnership with Target, you may have seen some press about that, is really a partnership between healthcare systems and farmers markets. And the goal is to provide healthy foods to high-risk families. This started here in Massachusetts with our first year. There were 3 farmers markets, and now it's spread all around the country. It looks a little bit different depending on the community, but most typically it's people who have diabetes or obesity or some other health risk where healthy food access, is highly likely to kind of change their disease trajectory. The prescriptions are written in a healthcare setting, and they come with private dollars to access healthy fruits and vegetables. They typically target families, so really family-focused programs for all of these, where the lift comes to the whole family, which is a little bit different than school programs, which we'll talk about next. So the way the fruit and vegetable prescription programs work, there is a dollar total based on the number of household members, and you see that similarly for the healthy incentive program. So rather than targeting, the one child in WIC that's under 5, or you may have 3 or 4 more other children, and you're actually trying to distribute that across the family, it really is meant to target the entire household. Next slide, please. So I'll talk briefly about school and after-school programs, and this is a place where I've worked less, but certainly a really important pillar of food access, particularly in children. Important because it targets children directly. There's both pros and cons to that. If, a child is bringing home food that's being distributed across the family, you can see where that may not be as much of a lift to the entire family. But the flip side of that is really that by targeting the children directly, some of the kind of social stigma and concerns that families may have may be overcome, right? That the child may come home with a backpack or do something else, and the family will be more apt to take that help that's given to the child directly than, sign up for a more formal program. They've been shown to improve behavioral and educational outcomes. Debbie talked a bit about that. In school, the most common are school breakfast and the backpack program. Now, school breakfast, there is, support for school breakfast below specific income levels in school systems. Many schools in underserved communities have taken the approach that, in an underserved community, many more children are hungry than realized, and many children who may have food in the home may not have kind of the level of organization needed to prepare and eat breakfast before school. So many schools are starting to offer free school breakfast for all children, regardless of income status, and seeing good results with that. Backpack programs we'll talk a little bit more about, but backpack programs are really designed to send children home, particularly for weekends or for vacation weeks or longer weekends, with food that will help sustain them over that time period. The challenge is, of course, that you're limited in the perishable items, particularly if you're sending a kid home for spring break, but really an important program. In the after-school space, Kids Cafe is one of the big ones, so really thinking about how to offer foods similar to the breakfast program in after-school programs and make that part and parcel of all the after-school programs in a community. And then there are large initiatives around summer meals, because many children are food insecure in the summer because they lose their access to things like the breakfast program or the reduced lunch, et cetera. And so that really allows them to typically go to a specific place and go get summer meals. Next slide, please. So I'll stop there. Are there any questions before we move into the Utah Community Action Program?
Yeah, so there are a couple that have come through. Several are more just comments, but we'll go ahead and share those out as well. So whenever you were talking about the maps around the SNAP decreasing, the grocery stores that accept SNAP decreasing, as well as WIC, so comment that people had never considered this large an area as not accepting the SNAP benefits, and then kind of a confirmation on the issue around WIC. So I think you had said that there are less areas, or there's more areas that are discontinuing WIC. Is that true?
This is a clarification question. There are, if you flip back to the graph, can you flip back to the graph for 1 sec?
Yeah, let me get back here somewhere.
Yeah, right. Next one. Yep, right here. So there are the percent change, right? So it's a little bit of a complex measure. So there are a lot of areas in the country where WIC access is decreasing, Much of it's a modest decrease, but again, you know, in an administration that was working very hard to promote healthy food access. So, you know, the barriers are real. There are, as Debbie brought up, you know, there are big cuts to the Farm Bill coming. There are a lot of concerns out there as we try to kind of balance our budget, you know, about what will happen to this. So, yes, it depends on where you are in the country, right? In some places, you know, California is largely doing better over that time period. So it really depends on where you are. So I don't want to kind of make a sweeping generalization that this is happening in everyone's community, but it certainly is a concern.
Okay. Great. And there was another comment just on the fact that it seems like many families are not accessing or picking up WIC services, even though they're eligible. Instead, they're going to other services and kind of refusing to pick up the WIC benefit.
Yeah, and that's gotten better over time, actually. So, you know, prior to, I think it was 2010 where they did the big changes, the WIC food package was not very healthy, honestly. So a lot of families didn't really find it to be a big benefit, or at least the ones that I served. I mean, they told me that they just didn't want that stuff. And so with the revamping of the WIC package, they've seen a much better uptake. But still, there are a lot of families that don't access it. There's a huge drop-off after formula, where families don't really feel that the program is as beneficial, or, you know, kind of in the community, it's WIC is for formula, at least the ones that I have worked in. So WIC is working really hard to change that, and certainly in my past 15 years or 14 years in practice, it's changed dramatically in terms of people's willingness to access WIC, but I think we still have a long way to go.
Sure. All right. Well, thank you. I think that does conclude the questions and comments that we have. Actually, one just came through, so we'll go ahead and address that one real quick, and then we'll turn over. Do you know of any strategies to increase participation in the summer meal programs? Transportation is not available. Parents cannot drop children off on their way to work, so supervision for children at summer meal sites is also an issue.
Yeah. Go ahead, sorry.
No, that was all for that one.
Okay. Yeah, this is a really challenging problem that many people have worked on. I think the strategies that have worked well is to kind of co-locate summer meals programs with other programming. So, you know, if you have a Y summer camp, to try and see if you can work with the Y and create a partnership and distribute the summer meals program there. That can be really challenging. It just depends on the partnerships you have. That's been, I think, the most effective. Some sites have tried something a little more like a backpack program, so something that can, you know, something less perishable, where there could be a once-a-day pickup, things like that. I've seen less of that in the literature and in practice, but I think that's another possibility.
All right, thank you. Okay, well, we'll go ahead and go on to the Utah Community Action. We have Joni Clark with us from this agency, and she's going to talk a little bit about their Central Kitchen and Nutrition program. Joni? Are you there, Joni? We can't hear you. You might be on mute. All right. Hold tight, everyone. We'll address these technical difficulties real quick.
While you're doing that, this is Deborah Frank. Can I add one other point, which is there's a summer EBT program that was highly successful in reducing food insecurity, but of course is not being adequately funded, but particularly in rural areas where, as someone pointed out, just getting kids to these things is impossible. And besides which, in a lot of the country, it's so hot you wouldn't want to send a child out. Just giving families for 2 months extra EBT cards for school-aged children with the equivalent funding of the cost of 2 months of school meals has a well-documented impact. Again, it's a matter of political will. There's also a problem in terms of WIC, which I learned from a grocer, which is that the sign-up, the monitoring and enrollment characteristics for stores for WIC are much more burdensome than for SNAP, and that discourages some stores from participating. And, you know, it's been recommended that these be streamlined, but as far as I know, nothing's happened. So in terms of, in the questions that folks already brought up, I thought that might be helpful.
Sure, thank you. All right. Still cannot hear you, Joni. Try unmuting some of these call-in users. So I apologize if there's other people I'm unmuting.
Can you hear me now?
Yes, I can.
Oh, great. So sorry about that.
Okay, so you can go ahead. I'll bring up the next slide.
I was just thanking the panelists for their comments. It tees up very nicely as to the reason why we started this program, our Central Kitchen program back in 2009. We are a CAP agency, and one of our programs is Head Start. We serve about 2,100 children in poverty. The average family of 4 makes about $17,000 a year. So we, back in 2009, were really looking at the food that we were serving our children. We were noticing high rates of malnutrition and obesity. And we were serving them food that sort of was like a Meals on Wheels. It came on a tray. The teachers would heat it up. The food was all the same color when it came out, and we were noticing that the kids were not eating the food, and that was a problem. In order to get them developmentally ready for school, they needed to be healthy and they needed to be eating. So back in 2009, we searched high and low in our community for a vendor that would be nutritious for our kids, kid-friendly food, and at a nonprofit price point. And as you can probably tell, that did not happen. So we decided to start our own Central Kitchen program. We hired a chef from South Carolina. We hired a nutritionist, and we got together to develop very healthy, nutritious meals. We had a private funder, Morgan Stanley Bank, as well as a local food purveyor, Nicholas & Co., invest in the project. Next slide. And what began with 300 meals has now turned into a venture of serving 597,000 meals made from scratch and served hot daily, and it provides 2/3 of our child's daily nutritional value. Next slide. We have since built our own kitchen. We use new market tax credits and private funding to build this $1 million project. It is a central kitchen that is just off of one of our largest Head Start sites. Next slide. We produce 4,300 meals daily, and that is all made from scratch. We have no canned fruits or vegetables. We only use whole grains, wheats, and pastas. Next slide. Next slide. And fresh poultry. Here's just a little bit of a look at our kitchen. Next slide. As you can see, like I said, nothing canned, all whole foods. Next slide. We go green as well, so we eat off of regular plates and forks. Our kiddos will eat family style in the classroom. The teachers are educating them on the food while they're eating it. So plates are delivered, and then the dirty dishes are picked up at the end of the day, taken back and rewashed. for us to start the next day. Next slide. We have about 5 different routes that we take in our box trucks. The food is in these Cambros, which is on the bottom right-hand picture. It will hold temperature for up to 4 hours. So when the trucks leave our site at about 9 a.m., the lunches are fresh and hot when the classrooms start eating between 11 and noon. 41 different sites and 146 classrooms. Next slide. With our kitchen came many nonprofit partners and schools and daycares that wanted our food. So we have built a social enterprise. So that money that we obtain from our outside clients goes back into our programs that we then use to pay for either healthcare procedures or classroom materials, whatever our greatest need is. And we make about $40,000 a month in revenue. Next slide. We have also adopted a program that's called Sauté. So it is a workforce culinary arts training program for our Head Start parents. They go through a 10-week course that gets them everything they need to do to get a job in the culinary field. So cooking classes, knife skills, sanitation. We also provide them with a ServSafe certification, which is above a step above a food handler's permit. And then we are able to help them get jobs in the culinary arts field. Next slide. We also have a catering arm, which the Sauté students will help us. We will cater outside parties, we'll cater events in-house, and that gives them sort of a different on-the-job feel. So when they leave our program, they can work in a restaurant or they can work in a catering company. Next slide. This is one of our events that we do every year. We cater a crawfish boil for one of our donors, and it's all done with Sauté students. Next slide. Another example is our partner appreciation event, which is all done by Sauté students. Next slide. And our NCAF fundraiser that we do every year. Next slide. And here's a look at some of the food that is prepared for these events from our Sauté students. Next slide. Next slide, sorry about that. We also do a summer dinner program. So all of the lunch programs in our community are great. We're the only ones that offer dinner. So we do 4 sites. We serve about 6,500 meals at these sites, and we get about $13,000 in profit back in that program. Next slide. Through our Sauté program, we ventured with the Salt Lake County to run one of their cafes in one of their rec centers, and we provide, this gives some of our graduates from the Sauté program who do not have enough on their resume to get a job, we give them a temporary employment opportunity at the cafe for up to 6 months. And at that cafe, we serve about 600 meals for seniors. And that helps feed into the total of $40,000 revenue into the program. Next slide. We also do a Kids in the Kitchen and Nutrition in the Home program. So we have noticed over the years that we are making an impact with the malnutrition and obesity rates, but we're only seeing those habits in the school. So we have done a lot of work to take the healthy habits and into a Nutrition in the Home class. Where we will identify the families that are still struggling with malnutrition and obesity. We will bring their families in and have an intensive course with them on how to cook on a budget and how to cook healthy. They are then sent away with recipes and groceries for the week, and we're noticing that those healthy habits are going into the home when we do our pre and post testing or assessments. Next. We also have a farm in which it's about a little over an acre, and we teach a youth development program that teaches leadership skills, job training. With that food, we also bring it back into our kitchen to be made for the children, and we also run farm stands, which this year we have started accepting SNAP. So we're very proud of that. Next slide. Here's just another picture of the youth. Next slide. And we're proud to say that our Central Kitchen program was recognized by First Lady Obama and the White House chef Sam Cass. Next slide. that is it. What questions do you have?
All right, thank you, Joni. We appreciate you sharing that, and we'll let everyone have a minute or two to type in any questions that they might have. I've had a few people just comment to me privately in the chat that this has been very helpful and a very informative webinar, so that's great. All right, and what I'll do is I'll go ahead and go through, actually we just had a question come in, so we'll go ahead and address that. All right, so I had a question about whether you all use organic foods.
Yes, so Utah Community Action uses organic when it's available. We have a partnership with our food purveyor that will give us school food pricing for organic when we can get it. And as long as it's within our price point, we can do that.
Okay, great. And then there's another question about Sauté. It says it looks to be a great training program. Who did you partner with to establish?
Sure. So a lot of the funders of this program are through Community Reinvestment Act banks, whose focus is on workforce development. So we do a lot of fundraising with corporations and businesses in the community that really target workforce development and job creation. So Morgan Stanley Bank, Ally Bank, GE Bank, to name a few. And we have gotten some funding from the Walmart Foundation as well.
Okay, great. Another comment and question. Seems like you all do a lot of great work. How do you handle the capacity to serve so many people? Is part one of the question.
Yes, so we spent a lot of years developing a business plan, and we had some business entrepreneurs in the community help us launch this program, and they also did a business analyzation that basically says as we increase by 500 meals, that is when we need to hire a new driver and increase capacity. So our current kitchen that we're at, and probably our last, has the capacity to go up to 6,000 meals a day. And so we're just very careful and deliberate on when we do increase to make sure that we keep on that path to self-sufficiency and able to maintain our costs.
Okay. And do you hire people to cook the meals during the school year, or does Sauté also cook those meals?
So we have our own designated cooks who are also the line drivers. The Sauté students will help us prep, cut up some fruits and vegetables for the next day, but it's mainly done by our 7 line cook drivers. And we have, however, hired some graduates from the Sauté program when jobs have become available in our central kitchen.
Okay. And then how many paid staff do you have at Central Kitchen?
We have 9 total. We have a kitchen manager, a nutrition coordinator, and the rest are line cook drivers.
Okay. And then do you have a idea of what % of your Central Kitchen staff are former Head Start parents and or graduates of Sauté?
I do. About 50% of our line cook drivers are parents and or graduates.
Great. All right. And do you all partner with public schools with any of these programs?
We do not currently. The public schools here in our community use their own food. So in fact, there is about probably 600 of our own Head Start kids that are at sites in the public schools, and we are not able to feed them because the public school uses their own food program. We are in negotiations right now with 4 private schools who are looking at using our food.
Great. All right, well, I don't see any more questions coming in at this moment, so I'll go ahead and go through our last few slides. As you see on the slides, on this current slide that's up, Joni's contact information is on there, as well as some of the other Utah Community Action staff members. So I encourage you, I had a couple comments about people maybe looking to start a similar program with a central kitchen idea. So, definitely if you have questions as you might be embarking on that sort of thing, feel free to reach out. All right, so if you want to engage in more discussion around this, we will be having a subgroup call on the health and food and nutrition topics. So we'll be discussing a lot of what we've talked about today, but it'll be a 1-hour format on Wednesday, August 2nd at 1 p.m. Eastern Time. And this will be mostly just a call, so we'll have a couple slides up if you want to join via WebEx, but you don't have to. And this will just really give, it'll be in a meeting format, so you'll be able to talk and engage with your peers a little bit more. So if you want to talk through any programs that you're thinking about implementing, or just talk more about some of the information and data that you saw today, we will have Dr. Charlie Homer on the line, and there's a chance we might be able to have some others, maybe someone from Utah Community Action as well, although I have not confirmed that yet. So we might be able to talk more about that piece as far as the central kitchen goes. And we can always field questions out if things come up in that, if the subject matter expert is not on. So just to let you know where everything will be housed after this webinar, we have several technological tools. Basecamp is one of them. So if you participated in this webinar today, I will add you to the Health Intersections Basecamp site if you're not already on there, so that you can see all of the updates from this learning community as well as the slides and recording. That's usually where it gets posted first, as well as the lcrcweb.com, that's the Learning Community Resource Center blog. And so if you haven't checked that out, please do so. You can subscribe to be able to follow the Learning Community blog and receive regular updates. So that'll be where you'll see a lot of those resources show up first. There'll be a PDF of the slides as well as the recording of this webinar. And then we'll also send a follow-up email to anyone who registered for this webinar to receive those materials as well. Just a plug for our 2017 annual convention. We'll be having more topics around health intersections at the convention, so encourage you to come and get some great workshops on this topic as well as others. So I don't know if we'll be focusing specifically on food access and nutrition, although most likely there's something related to that, but there is one on the health and wealth connection, as well as others that relate to health intersections. So that's at the end of August through September 1st, and we're excited to have great registration numbers that have come in. Another piece that'll be coming out is we have our Learning Community Practice Transformation Mini General. So we'll have some agencies presenting their successes, challenges, and lessons learned through their learning community projects. And that's on Wednesday, August 30th. So thank you all very much. We appreciate your time today as you've joined in this webinar. We do have one more question before we go. And it's saying, for the other panelists, how do they view the importance of organic food in young children's diet versus fresh fruits and veggies?
It's a complicated trade-off. Again, I think in a lot of studies, the benefit of fruits and vegetables, or for example, in the case of fish, seem to outweigh the risks of potential contaminants. The trouble is that that is such a local calculation, and that in certain places, i.e. Flint, Michigan, say, the contaminant problem certainly outweighs the benefit of drinking tap water. So I think that's it's not a very, there's no simple answer. And also it depends on the food that, some non-organic foods have much less contamination than others. And the problem always comes down to expense, that in most settings, organic food is more expensive than non-organic. And so if it's non-organic or nothing, we usually trade up to, we usually accept non-organic, but it's not a simple answer. I know, Shikha, do you feel differently about that one?
No, I agree completely, and I think that the economics are really important. So, you know, if it was easy to get nutrient-dense organic foods to, you know, to every kid I've worked with, either in a programmatic or in a clinical setting, that would certainly be my preference. But I think what we end up seeing is even in farmers markets that I've worked with that are primarily organic farms, we actually see families purchasing things like potatoes that tend to be cheaper, or, you know, bananas typically aren't available at farmers markets, but we might see that in more of a grocery store. So you see the less nutrient-dense foods and more calorically dense foods being purchased in those settings, and I think that that's a bit of a challenge. So I personally don't necessarily push organics, you know, either with my patients or in the programs that I work with because of that trade-off.
All right. Thank you. Thank you both. And then one last question for Joni, and then we'll go ahead and close out the webinar. Joni, can you repeat your revenue generations from the food sales?
Yes, all between catering, the outside food clients, and the cafe, we bring in about $40,000 in revenue each month.
Thank you. That's great. Okay, well, thank you all very much. We appreciate all of your time. Thank you to the panelists for presenting on this webinar and sharing such wonderful information with the Community Action Network. And thank you to all our participants for joining in. If you do have any additional questions, please feel free to contact me. I'm Courtney Kohler, the Senior Associate at the Community Action Partnership. There's also other contact information in this presentation, but I can make sure to field your questions and get answers back to you. So thank you so much for your time, and have a great day.
Our pleasure. Bye-bye.
Thank you.